It's more, we need to add some.
Oh. Right. What are you doing here?
Huh?
What are you doing here?
I'm not there yet.
That's good.
Okay, so you can change. You can pick a team. You get to pick your own team.
Team on your own.
Huh?
Team of one.
You team.
Oh,
Up.
team.
Two of one?
There is.
Oh.
Or it could be a Y.
Do I want to know?
How old?
Oh,
3 hours.
so I don't.
I think Dr. Beam will echo my symptoms.
Are you guys impatient? Or are you ready?
I am impatient. I'm also impatient.
It's nice to be impatient.
Like I told.
It's nice to be inpatient together. It sounds like Sesame Street.
It's true though. Rather than being so better,
I have a Charlie impatient.
it sounds fun.
Just like overnight.
Oh, someone just logged
They
on.
have an office too.
What?
So it's in there.
Ah.
I don't even know how to use it.
She said someone just signed on.
Yeah, I'm all happy.
I didn't. Am I supposed to?
Well, I didn't get that.
Wait, are we supposed to join while we're here or not?
No, you guys don't need to join. This is so we're experimenting so ambulatory can sign on from there for new conference. Let me just call Sean. Just to make sure, I want to make sure that. Hello? Hi, Rashawn. Are you with Sapam? Can you see anything? Okay, so when you have an answer, at the time of the answer, just use the chat button to chat in your answer. Just type in it, okay? Can you hear us?
No.
Oh, we're physically.
Okay, yeah, yeah, but I'm in front of everyone. Okay.
They are one of them.
Give me a second. Okay, we're on record.
It's there, but they and the girl.
I love that.
Yeah.
Hello.
She's big. You could join. You would.
I was a skeptical, and I think when she found out, I think it was like, I would also like to
Oh, she was born like 2 weeks ago.
Okay.
Yeah.
All right, you guys, it's not gonna work like this. We're gonna go into 2 round groups. And you're gonna select one person to be, the person who reports out for the group, okay? So circles. Oh, no, you need a mixture of third years, interns, and students.
Trust me.
So you want 2 circles.
Right. I'm wondering, because questions are not necessarily so easy. Where's the other team?
Impatient?
Yeah, where's the other? You are the other team.
He answered what he's still running, but I'm from Team A.
Okay, and where's she Sue?
He's still rounding. Yeah. We broke. I finished first when I came.
Okay.
Marianne's up this weekend.
Okay. Okay. This is, okay, does anyone know how to make groups? This is like kindergarten.
Gather around.
Okay. Okay, so you go over here, you go further that way. Yeah. Yes. Okay, turn around. Okay, you turn. All right, we have teams.
One of ours.
What?
Or
One of your interns? What?
Oh, right.
Okay,
So
you
the
need to
next
turn this
stage
way.
here.
Do you not know anything about comprehension?
I don't know.
We're asking for trouble, Ronnie.
Ah, all right. Oh, and can I ask you to keep score?
Exactly, that's
All
why
right,
it's
so we have
here.
Team A, Team B, and ambulatory. Why don't you join here? Yeah. let's do it.
Oh, there's one right there.
All right, so this may be like semi-obnoxious. Part of this is an experiment in that we are taping this, and so people can watch it dysynchronously, and we are having them watch it in ambulatory, and they should be texting our answers. So let us get started. And you are Team A. The rules of the game for this will be a little bit different. Okay. 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 I don't know how to shut that off. Do you have a volume thing that we can turn the volume down? This is like some kind of IT hell. Okay. All right. So the way we're going to do is everyone each team, except for ambulatory, will get to pick the category and the number. I will give everyone a chance to answer, and we will let everyone answer. And there will be extra points if you have a good explanation for the answer. So, Team A, Team B. Team A, pick a category and it does not have to be. The answers do not have to be said in the form of a question. Okay, so pick a category and a question.
Bleeding disorders for 100.
Bleeding disorders for 100. Okay. Yeah, so you're gonna move closer. These are complex questions, my friend. All right, reading out loud. 43-year-old with liver disease is hospitalized after massive vomiting of blood. Medical history is notable for alcohol dependence. He takes no medications on physical exam. His temperature is normal. Blood pressure is 102/68. Pulse is 118. Respiration is 22. He has jaundice. He has spider angiomata on his anterior chest. His liver is palpable but not tender. His PTT is 45. His PT is 17. Hemoglobin 9.8. Platelets 42. D-dimer 5,800. Fibrinogen 66 milligrams per deciliter. He receives volume resuscitation with fluids. He gets packed RBCs. He gets platelets and vitamin K. Which of the following should also be provided to manage this patient's coagulopathy? Which of the following? All right, so discuss. No, discuss amongst yourselves and tell me when you're ready. And yes. What?
Stefan said he can't hear so well.
Maybe it's because I'm not. Can you see?
He can't see the question on the screen. Oh, video. Why is it?
You shouldn't, because it's not really a video.
Alright.
All right. He can't see because I'm sharing, and you should be able to log on and see it. See if you can log on with your phone. All right. So Team A, what is your answer? How would you further treat this patient? Cryoprecipitate. Team B?
FFP.
FFP. All right. So it is cryoprecipitate. And why is it cryoprecipitate? For an extra 100 points.
If I break it, it's like-
Because, okay, yeah, so it's cryoprecipitate because cryoprecipitate contains more fibrinogen than FFP and is the blood component of choice for a patient who has low fibrinogen less than 100. So that is why you would choose this. Okay? I would choose that team. They're already ahead. Okay. Okay.
Get 200. Was that a double jeopardy?
Well, I made it a double jeopardy because you had to
we
go.
get 200 for that one.
Okay, you're already winning, for God's sakes. Come on. All right. So so you get to pick again what category and question?
Platelets for 300.
Platelets for 300. Okay. 42-year-old man admitted to the hospital with acute change in mental status and fever of 2 days duration. Medical history is non-contributory. He takes no medications. On physical exam, temperature is 100.8 because we're in America and we use Fahrenheit. Blood pressure is 108/70. Pulse is 104, respiration's 18, oxygen saturation is 96. He's breathing ambient air. He's agitated, disoriented to time and place. There are petechia noted on his shins. The remainder of the examination is normal. Haptoglobin's 20, hemoglobin 10, WBC's 9.8, platelets 44, reticulocyte count 6.8%, creatinine 1.4, LDH 1600. The direct Coombs test is negative. What is the most important next step? Next test. What is the most important next test? For $300.
Yeah.
Okay. Team B, what is the most important next step? Peripheral smear. And yeah, I did it wrong. That's cheating. Okay, so peripheral blood smear, and what are you looking for? Just the site straight. And there are no extra points for that. You should be able to come up with this answer in a coma. So they both got 3. Team A got 300 too.
Very generous.
I know. I gotta learn how to do this better. Okay, but I'll let you pick from the categories right now. What would you like to do? Two run. Okay. What?
Thrombosis 1 300.
This is 300. A 50-year-old woman undergoes follow-up evaluation for right femoral deep vein thrombosis diagnosed 6 weeks ago. Can you read that?
Yeah.
All right. I'm just reading it out loud for SAPON in the ambulatory. Okay. She notes right leg edema, which is improving. She has no history of travel, surgery, and mobility. She indicates feeling well before a diagnosis, no shortness of breath, had normal colonoscopy, normal mammogram, and pap smear 6 months ago. Medical history, otherwise unremarkable. Only medication is rivaroxaban. Physical exam, vital signs are normal. She has mild edema of the right lower extremity. The examination is otherwise normal, which is the most appropriate diagnostic test to perform next.
This is what we both see. We just see the beginning of the thing. So I'm wondering if the way that you're screen sharing, if we should do it through the PowerPoint or how you screen shared it originally.
Sharing is pause when you're sharing.
Resume share.
Ooh, where's resume share?
Oh, now I see it. Okay.
Still there? Is it right?
Yeah.
Okay. So Okay, first off, your answer?
D.
D, no further testing? Okay, correct. No further testing. All right. Any ambulatory, if you want to chat me an answer. All right, no further testing. What percent? Okay, for 50 extra points. For 50 extra points. What percentage of older people with unprovoked DVT get diagnosed with a malignancy in the subsequent 12 months?
30%.
Yeah, see, she already gets, it's a team. She already did. Guys, oh my gosh. All right, it is 10%. It is 10%. Okay. Nobody got extra points. No, you don't get extra points. You gotta be like a team. That's what the idea of team stuff is. All right. Okay. Want to pick? Thrombosis 2 for how much? Okay. 25-year-old woman admitted to the hospital with a right lower lobe pulmonary embolism. Mother also had a deep DVT 25 years ago. She's placed on IV heparin, weight-based. On exam, blood pressure is normal, pulse is 120, respiratory rate's 19, oxygen saturation is 91%, breathing ambient air. Otherwise, the exam is normal. Despite increasing doses of heparin, her PTT time remains in the normal range. Which of the following is the most likely diagnosis? Talk amongst yourselves. You're close here, so don't let anyone hear your answer. You can see the answers too. Oh, all right. Well, we find out that one of the things that nobody sees it. Only he sees it. Okay? No, he hasn't. But that would be kind of unfair, wouldn't it?
Yeah.
All right? Okay. What's your answer? Antithrombin deficiency. Your answer? What would you like? Oh, no. You have to have decided beforehand. You say antiphospholipid. Okay. So it is antithrombin deficiency, and I will give you an extra 50 points if you can tell Team B. And right now I don't know which is Team A or Team B, so that's okay. Why it is antithrombin deficiency, other than it seemed like a good idea at the time. Physiologically, why does this represent antithrombin deficiency?
Because it's refractory to heparin. Heparin forms a ternary complex with antithrombin.
Correct. So heparin actually has to form, don't be embarrassed, I'm very proud of you, has to form a complex with thrombin to actually be effective. So when you have antithrombin deficiency, the heparin is ineffective. So they get a 50-point thing. Ooh, you guys are killing it. Okay, what pick? No, yeah, blank is blank. Blank is really blank. Okay, thrombus 1 for 300. Actually, that was already done. It's just for 400. This is a double jeopardy. Okay. Shoot. Did you see it?
I didn't see it.
Okay. 70-year-old man is evaluated in the emergency. So it's double jeopardy. So you could take 400 or you can take a little bit more. I'm letting both of you like pick your point number, but it will be subtracted if you get it wrong. Okay. It will be subtracted. I really have to learn how to play this game. A 70-year-old man is evaluated in the emergency department for headache, confusion, weakness. Medical history is significant for ischemic cardiomyopathy with heart failure and a mural thrombus. Medications are lisinopril, carvedilol, spironolactone, furosemide, and warfarin. On physical exam, he's disoriented. His temperature and respirations are normal. Blood pressure is 160/90. Pulse is 88. Examination is otherwise unremarkable. INR is 7.5, and he has a CAT scan that shows an intraparenchymal hemorrhage. In addition to vitamin K, which of the following is the most appropriate treatment? No, actually, I want you to actually not have the selection. I need you to tell what's the next thing that you would give to this gentleman. This is a patient with cardiomyopathy, AFib, INR 7.5, with an intraparenchymal hemorrhage. What is the next thing you order in the ER?
Yeah.
Okay. Tell me when you're ready.
600. This is our answer.
Which is what? That's the brand name. Kcentra is what? Oh,
The 4.
okay. And your answer is? Your answer is? Actually, we should just put it on pieces of paper. 400. And what's your answer? Okay, so the prothrombin complex. And that is correct. So they get 600 points because they add more. They get 400 because you asked only for 400 points. That's what you said, right? Yeah, you did. You did say that. Yeah, you kind of did. All right. Wait a sec. Have they gotten down to, how did they get only 600? Did they get wrong answers? Oh, I'm so sorry. Okay. No, they got 4. They said Kcentra, which is 4-factor precipitate. Who's gonna tell me? What?
Sorry, I didn't add it yet.
Oh, okay.
Oh, okay, phew. Oh, phew. All right, and so who's gonna tell me why? Why did you choose that? Why is that the next thing?
Onset of action.
That-
Take longer.
What? The FFP would take longer, and why? Because an active bleed, yes.
Oh,
So,
less volume. For
FFP is
the,
like 250.
so there's less volume, that's one, but she is also correct.
Mhm.
The FFP requires a cross match, it requires thawing, it never is, there's a whole bunch of issues in FFP that makes it take longer to act before it can be administered. That's why it's 4-factor precipitate. All right. Right? The 4-factor precipitate does not require thawing, it doesn't require typing, and it's not that as much fluid. All right. Next to pick.
Thrombosis for 500. Thrombosis 1.
For 500. Okay. 25-year-old woman is evaluated in the emergency department for mild shortness of breath and right lateral chest pain of 2 days duration. She reports no orthopnea or lower extremity edema. The medical history is unremarkable other than anxiety related to meeting the demands for a new job as an engineer. She takes no medications. Physical exam, she has no apparent distress. Vital signs are normal. Oxygen saturation is 99%. Lungs are clear. Her no edema. Wells criteria for PE is 0. Complete blood count, electrocardiogram, and chest radiograph are normal. Which of the following tests should be performed to rule out pulmonary embolism? Okay. 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 All right. We're gonna. I should have you write it on a board. On like I'll bring white. I'm gonna bring like little white things next time. Okay. So you choose. All right. You choose. What one person has to tell me which one. No further testing. All right. And so, yes, that is the correct answer. No further testing. So why is it not D-dimer?
The Wells score is 0. Both pretest probability is for having the.
So when does the Wells score suggest that you should, what calculation of a Wells score do you start deciding maybe I'll use a D-dimer?
Score 1.
So it's when it's an intermediate probability. If the Wells score has a high probability, you don't do a D-dimer. If it's 0, you don't do a D-dimer. It's only if it's an intermediate probability. And remember, for the boards, they're probably going to give you the information. Sometimes they'll give you the Wells score. Sometimes they're just going to give you the information so you could calculate that one in your head. There's something else that is used. Who knows what the the pulmonary embolism rule-out criteria, right? So that's also used in combination with the Wells score to stratify patients. Okay. Yeah. Platelet disorders for 500. Go for broke here. All right. 68-year-old man is evaluated for epistaxis, gum bleeding, easy bruising of 3 months duration. History is notable for anxiety, depression, hyperlipidemia. Medications are atorvastatin, citalopram, multivitamin, and ginkgo biloba. On physical exam, his vital signs are normal. BMI is 21. He's got scattered petechiae and several small ecchymosis on the anterior thigh. Examination is otherwise normal. His PTT is normal. His hemoglobin is 14. His WBC is 4.2. Platelet count is 245. PT is normal, and thrombin time is normal. Which of the following is the most appropriate diagnostic test to perform next?
Yeah. So this one.
Okay. So, do you want, okay.
Oh, we have a piece of paper, that's right.
The letter.
What?
The letter.
The letter. I was like, case entry, that's not a choice. It's like not a choice. And what? D? Okay. All right. So platelet function analyzer. So PFA. And I found this kind of hard because obviously you would always look at a peripheral smear, but in this particular case, what would you expect to find on the peripheral smear?
Well, platelets?
What?
No.
Nothing, right. And so on the peripheral smear, other things, because the platelet count was normal, he doesn't have signs of myeloma, right, where you might have some rouleau formation, you're not expecting schistocytes. We're expecting the problem is related to, maybe related to either the SSRI or the ginkgo biloba. Okay.
So we actually read about this and we're fascinated that platelets actually uptake serotonin and then in forming a clot, they release serotonin. So when then there's an SSRI, they can't take up the serotonin to release it.
And serotonin is a vasoconstrictor, so it helps with.
So we were like, well, this doesn't make
That
sense.
is pretty
Yeah.
cool. You really just should have made that like the 500-point Final Jeopardy. Would have been good.
We were thinking that too. So.
Yeah. Nice try
We
though.
knew it was the Mets.
Okay.
Wow.
All right, who wants to pick the next? Who's gonna? You're gonna take bleeding disorders for what?
500.
For 500. Okay. 64-year-old woman is evaluated in the emergency department for large ecchymosis, bleeding gums, hematoma extending from her upper thigh to her knee. Medical history is significant for CLL. She has been asymptomatic and has been managed expectantly. She experienced no previous bleeding symptoms and has no family history of bleeding disorders. She takes no medications. On exam, her pulse is 104, other vital signs are normal. Ecchymosis are present on arm and legs. Small cervical and accessory lymph nodes are palpable. Other examination findings are normal. What is the most likely cause of her bleeding? Okay, so actually, do I need to read out these numbers here? Because they're like minuscule. Okay. PTT is 88. With the mixing study, it goes to 64. Hemoglobin's 10. White count 65,000. Platelets 215. PT 11.5. Factor 8, 1%. What is the most likely cause of her bleeding, and how would you treat it? You can write that down. That's just brutal.
I'm gonna stay
Yeah.
outside.
Yeah.
I don't know where to go. I'm just gonna pick it up. Thank you.
Where's this?
Yeah, the other one.
Yeah.
I told we used to get.
Okay, tell me if you're ready to hold up your paper. Guys?
We didn't get it.
Okay.
something else as well.
Okay. And then call Raul and have him take it. Should have taken it. Okay. All right, guys. What are you gonna pick? Let's hold it up. Oh, there's two parts to this question. How are you gonna treat it? How do you what? Okay, I can read. Would you make it like? Oh my God! I'm like. All right. So the answer here, you guys only get part of this. So it is acquired hemophilia A, right? So because the PTT did not fully correct with the mixing study, you know there should be a presence of an inhibitor. That's the diagnosis of hemophilia A. But you treat it with activated factor VII. That's what it's treated with. Okay? You give them the downstream factor. Okay? Right? Because it's an inhibitor of factor VIII. So if you give them more factor VIII, it's still going to inhibit the factor VIII. That's why okay? So let's give them 250. Come on, give Team B. Thank you. All right? Just give them. I'm so glad she's doing that because I don't add really well. Okay. Okay, guys. No one's done thrombosis 2 for 500. Shall we knock it off the board? All right. 25-year-old man hospitalized for a DVT last week. He reported no recent travel, no surgery, or immobilization. His sister was diagnosed with an unprovoked DVT 1 year ago at 35. Medical history is otherwise unremarkable. His only medication is rivaroxaban. On physical exam, vital signs are normal. Examination is otherwise unremarkable. The possibility of inherited thrombophilia is discussed after reviewing the risks and benefits of additional testing. We would like to be further evaluated for a possible thrombophilia, which is the ideal testing strategy. You can write it on your papers. Okay, we're ready? Okay, everyone, write down what your answer. Write down your answer. Write down your answer. Write down your answer. You can't can make big nutters.
I don't like writing big. Oh my God, you have Parkinson's?
See. Okay, so temporary stop River Rock spent 6 months and test 2 weeks later. That's actually wrong. And both of you got that wrong, but I want to spend some time on this. First off, who wants to say why testing now is totally inappropriate? Okay, so he's not anticoagulated. Say he came in this morning, you haven't started anything, you can draw blood quickly and you're gonna start heparin. Would you test then? No, why not? Acute clot causes what?
Acute clot last week, so he's going to use up the thrombin.
Right, so it's gonna affect his protein S, C, and thrombin. So they'll be off just because of the presence of acute clot, and then once they're anticoagulated, they're the other issues. So that's the one. The other learning point that Mixap said was because it was an unprovoked clot in a young person, that it is safer to treat longer than our typical 3 to 6 months, right? If it's a provoked clot, if it was a provoked clot and he still wanted testing, you could treat for 3 months. If it's an unprovoked clot in a high-risk patient because it has a family history, you want to treat for 1 year. So apparently I would have also thought 6 months too, but
Close.
next.
Thrombosis to 400.
Okay. 77-year-old woman evaluated in the emergency department with a 3-day history of progressive abdominal pain, fever. Medical history is notable for AFib. Her only medication is Pradaxa. She took her last dose 16 hours ago. A physical exam, temperature is 102.3, blood pressure 90/55, pulse 115, respirations normal. She's abdominal guarding and rebound tenderness. The exam is otherwise unremarkable. The PTT is greater than 100 seconds and her creatinine is 1.7. Her CT scan shows a complete large bowel obstruction and emergency surgery is planned. What is the most appropriate management of this patient's anticoagulation? What do we do now? She's going to the OR. She took her Pradaxa 16 hours ago.
Reversal.
Okay. You two wanna, all right, answers?
Write at large, teammate.
Well, actually, they got someone different to write it.
It's just a small.
Oh my gosh! Oh my gosh! So it's spelled right. Well, okay. So we have Idarus. Idarusizumab is holding the dose.
That's
And it is correct. I stole someone's pen. I was up for like 30 seconds. When I stole that. How's that happen? All right, but why is that the correct answer? Why is that the correct answer? So what's the half-life of Pradaxa? What?
3 days.
Oh dear God, guys. It's 16. Why do you give it twice a day? Yeah, it's 12 to 16 in someone with normal kidney function. It is renally excreted. Her creatinine is 1.7. She had normal kidney function, potentially you would not have to do that. Right? So a couple of other things here. It has been tested. If you give, especially when the coags are off, giving FFP could potentially be of some value, but it's actually quite dangerous because as it wears off, Pradaxis is still being in the system and they bleed. So the antibody to Pradaxa is 95% effective in when they have to go to the OR. Okay. So if she had a normal kidney function, it was 24 hours, you would not have to give it. Okay. Anything else, guys? Who's gonna pick? You guys got it correct?
Bleeding disorders for 400.
Bleeding disorders for 400. 68-year-old man notes 3 days of melena, recent onset epistaxis, easy bruising. No bleeding problems until the past week. He's advanced ischemic cardiomyopathy and had a left ventricular assist device placed 3 months ago. He had no bleeding history before the LVAD, and his preoperative coagulation studies were normal. Medications are atorvastatin, carvedilol, lisinopril, spironolactone, and the warfarin that was initiated after the LVAD. Physical exam, other than the pulse rate, is 112. Vital signs are normal. Oxygen saturation is 94%. He has crusted blood in the left nair, scattered ecchymosis, multiple petechiae, surgical scar on the anterior chest is well healed. Stool for fecal blood is positive. The rest of the exam is normal. So going on to his labs, because this looks really tiny, the PTT is 40, the hemoglobin is 8, the platelet count's 130, the PT is 19, INR is 2, the platelet function analyzer is prolonged, the liver tests are normal, and fibrinogen is normal, 350. Which of the following is the most likely cause of this patient's new bleeding symptoms? Just as an aside, I really like this question. Tell me if you guys are ready. Guys? Thank you. I can read it. Okay. All right. Time to put down your chips, guys. Okay. So acquired von Willebrand's. And why that is correct. You both get 400 points. Why? And why does he have acquired von Willebrand's? Can you think of another syndrome where this kind of thing happens? As a very well-known syndrome. Associated with aortic stenosis, has a name. Hyde syndrome, right? So it's the constant chewing up from the LVAD causes activation and multiple multimers of von Willebrand's. So it's sort of a parallel to Hyde syndrome that you get. Next question. Why don't you guys pick? Platelet disorders for 400. Okay. 18-year-old in the emergency department, abdominal pain, cramping, bloody diarrhea, 6 days duration. Medical history is unremarkable. He takes no medications. Physical exam, temperature 98.6, blood pressure 98/60. Pulse is 100, respiration 16. Breathing normal. Normal breathing of ambient air. Abdomen is tender without guarding. Haptoglobin undetectable. Hemoglobin 6.1. Leukocyte count 6.8. Platelets 37. 98% reticulocyte count. Creatinine 3.6. Urine analysis 3+ blood. 3+ protein. 0 to 2 erythrocytes and several granular casts. Peripheral blood smear shows schistocytes, scant platelets without clumps. Direct Coombs test is negative. What is the most likely diagnosis? You ready? You ready?
No.
Writing. So this is HUS. What else are you going to test for? What? No, just so you would test for E. coli, Shigella, Salmonella, right? E. coli with the zip code, right? 7, right, right. And why would you do that? Is it going to change your management? No. So why would you test for it? Because it's reportable, right? These are reportable diseases. Okay. What? You're not that far behind. You could still pull this out. We got stuff on the board here. Okay. Bleeding disorders for 300. 74-year-old man noted to have prolonged bleeding time from bleeding from his venipuncture sites and new ecchymosis. He's admitted to the hospital 2 weeks ago for treatment of lung abscess. He developed C. diff. Oh my gosh, who has this patient on their team right now? Developed C. diff related diarrhea 1 week ago. His oral intake has been poor. Medical history is notable for hyperlipidemia. Medications are ampicillin, sulbactam, oral vancomycin, atorvastatin, and low molecular weight heparin. Physical exam, temperature is 100.8, blood pressure 115, respiration's 24. He's thin, chronically ill. Pulmonary exam, crackles are heard at the right lung base. Remember, the exam is normal. PTT is 30, hemoglobin 11, PT 22, ALT and AST are normal. Factor 5 is 100%, factor 8 is 100%, factor 10 is 24%. How would you treat this? How would you treat this? So that means you have to figure out why and then the how. No, I just want to tell you that I feel your pain so deeply right now. Okay, you ready? Okay. How would you treat this? Okay, so yes. Would any of you stop the low molecular weight heparin? No. And why not?
That's not the real problem.
And why do you say that that's not the real problem? What? No.
I mean, his hemoglobin is stable. Yeah.
Okay, so do you know there's a score? So how can you be sure that it's not heparin-induced thrombocytopenia? Because the platelet count's not even here. What? Yes. So what are the things in the 4T score? So if you get all the 4 things in the 4T score, I will give him an extra 100 points. 4T score? There's only 4 things, guys. You got the 4T part. Okay, come on, you can do it. Have faith in yourself.
I have no.
No, I have faith in you. I have faith in you.
So is the time frame in which
Okay,
the platelets drop?
so he does have that, right? Okay, so it's if they have to have 5 days, at least 5 days since heparin was started. So that's the one cutoff.
I think it's new evidence of
A thrombosis, if they have another thrombosis, right? Because they don't just bleed, they clot.
I think the drop in thrombocytopenia
The drop is
is 50%.
50%. And then the last one sort of I don't know why they even put this. What?
And you can exclude all of the causes.
If you can exclude all other causes. So in this particular case, there's no new clot and there's no, and you have another explanation for the bleeding. So from the 4T score, did you feel better, like knowing it with some background there? Because then when the question's different, you get it right. All right. All right, who wants to pick? They both got it right. I'm sorry, they both got it right. And he got an extra 100 points because he did come up with a, yeah, give him the 100. All right. We're running down. We only have 1, 2, 3, 4, 5, 6. 6 things. All right. Platelet disorders for 200. Okay. This is a double jeopardy one. You want me to read it out loud or not? Is it just getting annoying? All right. So 59-year-old man evaluated for swelling his left leg. He was admitted 5 days ago. Deep venous thrombosis, right lower lobe extremity, and bilateral pulmonary emboli. Therapy with low molecular heparin is started 1 month ago. I'm sorry, I can't even read. Other medications are lisinopril and furosemide. Physical exam, 100.6, blood pressure 132, pulse 104, oxygen saturation 91%. Hemoglobin, right and left legs are swollen to the mid-thigh. Hemoglobin's 12. White blood cell count, 11.2. Platelets, 78. It was 168. Doppler shows a new femoral vein thrombosis. This is easy. All right? Which of the following is the most appropriate management? Just write it down really fast. You know this. Right. So this is the 4T score. But we all know what the 4T score is already, and you already got your 100 points. Okay? So in this particular case, platelets were more than 50, drop more than 50%. You don't have any other causes. All right, go ahead. And oh, so they get 400 each, right? Because it was double jeopardy. They both got it.
Wager. I don't know how much.
No, yeah, I didn't ask them. we gotta get moving here. What? Bleeding disorders 200. Okay. 28-year-old woman evaluated preoperatively. She's scheduled for elective repair of umbilical hernia. Medical history is notable for heavy menses and 5 days of bleeding after extraction of wisdom teeth. Her only medication is an oral contraceptive. On physical exam, vital signs and other findings are normal. She has a normal platelet count, activated partial thromboplastin time, and PT are normal. Platelet function analyzer is prolonged, most likely diagnosis. This is, yeah. And let's have you write that out. Yeah, this is von Willebrand's disease. They both get 200.
Sorry.
What? Yeah, it's even. What's, you know, if it's a wash, why do the math? Okay. Yeah. 45-year-old man evaluated in the hospital for worsening pain, progressive swelling of the left lower extremity that began 12 hours ago. The medical history is otherwise non-contributory. Physical exam, pulse is 112, vital signs normal. These are erythema and marked edema on the lower extremity. The left foot appears cyanotic with decreased sensation, absent arterial pulses, and delayed capillary refill. The physical examination is otherwise unremarkable. Doppler ultrasound of the left lower extremity shows extensive iliofemoral deep vein thrombosis. Which of the following is the most appropriate management? Ready? Okay. So you guys are gonna, right, the clot needs to be broken apart. Okay, so we're even. And why does it need to be broken apart? Because he's starting to have compartment syndrome, right? Oh. Did you do this one already? Wait.
Yeah.
Okay, now I'm just picking them because what's the point? A 34-year-old woman is evaluated for rash on her lower extremity that appeared 3 days ago. She reports easy bruising for the past week and bleeding when she brushes her teeth. Her medical history is otherwise unremarkable. She takes no medications. A physical exam, vital signs are normal. Petechiae are noted on the lower extremities. Ecchymosis are present on the right thigh and her abdomen. No hepatomegaly, splenomegaly, or lymphadenopathy. Large and giant platelets are seen on the peripheral smear, but no schistocytes or platelet clumping is noted. Hemoglobin's 12, white blood cells 6.6, MCV 82, platelet count 28, hepatitis C antibody negative. Which of the following tests should be performed? So this is HIV testing. So common causes when you're thinking of ITP that you rule out, HIV and hepatitis C, which they already gave you. All right. And so what is the value of antiplatelet antibodies in ITP? Nothing, right? It's unreliable, unhelpful. "50-year-old woman undergoes follow-up evaluation for right iliofemoral deep vein thrombosis. Oh, we did it? Oh, sorry. Yeah. I forgot I accidentally decoded that one. Okay. 64-year-old man evaluated for progressive shortness of breath and hypoxia 18 hours after undergoing surgery for obstructing colonic adenocarcinoma with known liver metastases. Medical history is notable for hypertension, hydrochlorothiazide, physical exam, vital signs normal, oxygen saturation 92%, abdominal dressing is clean and dry, exam is otherwise unremarkable. CT angio shows a left lower lobe pulmonary embolism. What is appropriate therapy for this patient? Okay, long term. After he gets discharged, what are you going to put him on? What are you going to discharge this patient on? Okay, low molecular heparin. Thank you, guys. Both of you guys got it right. So I think this is important to know because there are studies now on some of the NOACs in malignancy, but our best data at this point is low molecular weight heparin and both the prevention of DVT and the treatment of clot in people who have active malignancy. But that could change sometime in the next couple of years.
Those are journal class.
Oh, okay. Yeah. Nice, easy one. 32-year-old woman evaluated for a painful rash occurring bilaterally in lower extremities. Began 2 days ago. She was admitted to the hospital 5 days ago for pulmonary embolism. It was started with heparin and warfarin. Her father had had a PE on a long airplane ride. Her medical history is otherwise unremarkable. Physical exam, vital signs are normal. She has non-blanchable macules and papules and areas of cutaneous necrosis and an angulated reticular pattern on the lower legs. Findings on the feet are as shown. Laboratory studies showed normal CBC, normal blood smear, and an INR 4. What is her diagnosis? Okay. What is caused that diagnosis? Okay. Okay, so this is protein C deficiency. A little more common than protein S. But in fact, if you had said protein C or protein S, that would have been fine. And that is warfarin necrosis. Oh, we are done. And you guys won.
What do we get?
Nothing. We had sheer joy. So let's see, how do I go to stop recording? Or maybe here.